We shall now go on to our next speaker, Dr. Tanuj, who is going to be talking on delayed hypotony after trabeculectomy. Again, a very important topic.
Thank you, Dr. Chitra. So in 5 minutes, I'll be giving a pre-recorded talk. And this is a brilliant resident from RP Center who has helped me, and his voiceover. So telling you 3 situations about how to manage hypotony maculopathy.
Bleb revision techniques for managing hypotony maculopathy. We have no financial disclosure. Trabeculectomy is one of the most widely performed surgery for managing glaucoma. This video demonstrates a series of 3 surgical techniques for managing overfiltering or leaking blebs causing hypotony maculopathy post-trabeculectomy. Transconjunctival compression sutures for overfiltering bleb. A 40-year-old lady with a history of right-operated trabeculectomy 1 year back presented with complaint of diminution of vision in her right eye for 1 month. On examination, she had right eye hypotony maculopathy with an intraocular pressure of 3 millimeters of mercury. She had a mildly elevated diffuse vascular bleb with no leak. AIOS OCT showed multiple subconjunctival fluid pockets and a wide intrascleral route causing excessive aqueous drainage. A 10-0 monofilament nylon suture was passed transconjunctivally from the limbus to posteriorly beyond the filtering area of the bleb. The plane of the suture is confirmed by presence of resistance felt against the needle while passing through the sclera. Multiple parallel compression sutures are utilized to cover the bleb area. Post-operative AIOS OCT showed reduction in the size of the intrascleral route, and an intraocular pressure of 16 millimeters of mercury was achieved by the end of 1 month with resolution of hypotony maculopathy. Avascular bleb revision using conjunctival advancement. This video demonstrates management of a patient who presented to us with a thin cystic avascular bleb and hypotony maculopathy 2 years after trabeculectomy surgery with mitomycin C. The conjunctiva over the thin avascular bleb was stained using trypan blue dye, and the epithelium is scraped off using a percent lint. The thin necrotic conjunctiva is removed, and the surrounding conjunctiva is undermined to create a phonic space conjunctival tenon flap behind the avascular bleb. The conjunctiva was advanced to cover the trabeculectomy site using 8-0 vicryl sutures at the 2 edges. And additional 10-0 monofilament nylon mattress sutures were put circumferentially to anchor the flap at the limbus. Post-operative clinical picture and anterior segment OCT showed a well-formed bleb at the end of first week. Management of hypotony maculopathy post-trabeculectomy with scleral patch graft and conjunctival overlay. This video demonstrates a surgical technique in a patient who developed hypotony maculopathy 4 years after trabeculectomy surgery. The patient's intraocular pressure was 4 millimeters of mercury, and he was found to have a thin cystic bleb with sweating and associated hypotony maculopathy. After local debridement of the unhealthy conjunctiva over the bleb, the surrounding conjunctiva was undermined to create a phonic space conjunctival tenon flap. Intraoperatively, the scleral flap was found to be thin and necrotic. A 10-0 nylon suture was used to close the existing flap, but due to tissue friability, the suture cheese-wired. After removing the necrosed scleral tissue, a partial thickness scleral allograft was fashioned and sutured at the trabeculectomy site using 6-0 vicryl sutures at the 4 apices. Additional 10-0 nylon suture was used to fix the donor sclera anteriorly at the limbus. The conjunctival tenon flap was then advanced over the scleral patch graft. Post-operatively, patient had good IOP control with resolution of hypotony maculopathy. Overfiltering and leaky blebs are a known complication of trabeculectomy surgery, especially with the use of antimetabolites. Each case needs to be evaluated individually, and the best suited surgical technique should be selected for its management. Thank you.
Thank you very much. Thank you very much, Dr. Tanuj. It gave us entire gamut of management. Would you think that your trap could still fail after an epithelial exchange bleb repair?
So I think that is definitely a risk. So first thing is there is no option because you have hypotony maculopathy and you have to do a site-saving procedure. So you have to replace it with healthy conjunctiva. These eyes are also at risk to go into blebitis and endophthalmitis. So when you replace it with a healthy conjunctiva and you advance the flap, definitely there is a risk that the function of the trabeculectomy will go down, and you need to follow up these patients over long term, and many of them require medical therapy to control the intraocular pressure. So definitely there is a downside to this, but there is no option in these cases.
Dr. Shailesh, would you have a question?
Yes, sir. Hypotony maculopathy, how many days do you wait? Because it can cause irreversible blindness also. I mean, what is the masterly inactivity period to prevent irreversible loss?
So I think, Shailesh, most of these patients come in the late post-operative period. So maybe many years after surgery, many months or years. That time, there is no role of conservative therapy, especially when you find that the conjunctiva is thin and due to mitomycin toxicity, the conjunctival barrier is compromised. So there is no point waiting. It is best to go ahead and change the overlay with a healthy conjunctiva, because you are leaving these patients at risk for infections and they can lose sight. So I don't think there is a role of conservative wait and watch policy if you have a late hypotony with maculopathy.
So looking into these things like delayed hypotony, do you refine your surgeries like concentration of mitomycin C or adding on Ologen to avoid such complications?
So first issue is avoiding complication. So long time back, we had switched from limbus-based flaps to fornix-based flap. That reduces the complications related to the bleb. The second is the wide posterior application of mitomycin C. That is a must. And if there is no risk factor, then we use 0.2 milligram per ml for 2 to 3 minutes. If patient has a risk factor for failure of a previous surgery, then we go ahead with 0.4 milligram per ml. And Ologen, we have tried extensively. There is no role of Ologen. It doesn't help. It just adds to the cost of surgery. And we did not find it enhance success in any way. And it's not at all a replacement to mitomycin C. So we are not using any wrong.
Okay, thank you.
How would ASOCT help you in planning your surgery in a delayed hypotony?
So that is very good question. ASOCT is helpful because to make the decision of having a scleral patch ready or just doing a conjunctival overlay. So on the ASOCT, if you find that there is a defect in the sclera or there is evidence of scleral necrosis, then you have to arrange for an eye bank sclera. And if in case because of the COVID epidemic, the eye bank sclera is not available, then you can do what is known as a Momini's repair. So you can raise a scleral flap from the adjacent sclera and rotate it and cover the area of the scleral defect. So that is another technique. Maybe I'll show it in some other webinar next time.
Thank you so much. Thanks a lot.